afternoon, and we'll start with the invocation from Chaplain John Gerhardt.
You're going to stand in there.
Thank you, Dr. Malone. Would you stand with me, please? And would you bow your heads with me for the invocation? Lord our God, we have been reminded in the past Holy Week through the observances of Passover, Good Friday, and Resurrection Sunday of your care for us who are created in your image. So we pause as we begin this meeting of our hospital board. We humble our hearts and we call upon you, our Creator. The task of caring for those in need is great. So we pray for wisdom, strength, and compassion for all of our staff. The burdens of sickness and infirmity are heavy. So we pray for your healing touch for those patients we can cure and dying grace for those we cannot. Guide our administration and the gracious members of this, our hospital board, as they seek to guide us in our unending mission to cure and to comfort all who come to us in need. These things together we pray. Amen.
I pledge allegiance to the flag, the United States of America,
And to the republic for which it stands, one nation, under God, indivisible, liberty and justice for all.
I'll call the meeting to order of the hospital board. And any citizen desiring to address the hospital board should turn in a speaker card to the board secretary. If the citizen comment pertains to an item on the agenda today, the comment will be heard early in this meeting. Otherwise, it will be heard toward the end. Speakers are asked to limit their comments to 5 minutes. Vendors, suppliers, or other persons seeking hospital contracts awarded on a competitive basis are reminded that their ability to address the board may be restricted by the terms of the invitation for bid, request for proposal, or other purchasing criteria. Lastly, the board has established a claims adjustment review panel comprised of representatives of the board, the medical staff, administration, and legal counsel to review and negotiate the settlement of claims. Accordingly, the board will not entertain comments on or discuss or to negotiate claims at this meeting. I need approval of the orders of the day, please. With any discussion? All those in favor, please say yes.
Yes.
Opposed? Carries. Thank you very much. Next, we need to approve the minutes of the meeting of March 17th, 2014. Any additions, comments? Hearing none, all those in favor of the motion, please indicate by saying yes.
Yes.
Opposed? Motion carries. Thank you. And we'll move next now to the Excel Award winner, Joe Garaccio, Supervisor Hospitality Services.
Are you in shock?
Yes.
So Joe is the Excel recipient for the month of April 2014. Joe's been an employee at Sarasota Memorial since July of 1993. Always dependable. Did you hear that audible?
Yes, I'm that old, right?
Always dependable, a can-do guy with a can-do attitude. These are a few words from coworkers and staff that make up the nominations for Joe. Here are a few comments. Joe does whatever it takes to get the job done. When asked to do something out of his scope, he will not say, call this person or this department handles that. He will take care of it himself or contact the person or department in charge to take care of it. Joe consistently goes above and beyond. His follow-up is excellent. He deals with all issues that are presented to him in a timely, professional, and caring manner. He makes you feel confident that the task at hand will be completed. He always puts patients first. Joe is always very responsive and positive. He is funny, but very caring. He goes the extra mile and answers requests immediately. Joe is a team player. He's always willing to troubleshoot for problems we encounter in infection control. He develops great relationships with fellow employees. I have had to contact Joe on so many occasions for help. Sometimes he's at the other end of the facility and he shows up right away to assist. There's never a doubt that he will take care of each and every request. Joe is always in a good mood. He's flexible with his schedule to accommodate department needs and goals. He is the go-to guy in environmental services. He's truly a team player in the sense of the hospital being a team versus just his department. Congratulations, Joe.
So, congratulations. I'd like to read this plaque on behalf of the board. The hospital board and administrative staff of Sarasota Memorial Healthcare System are grateful to all employees who consistently enhance the value and the quality of a patient's stay by making an extra effort in their daily activities. The Excella program is designed to recognize employees who have distinguished themselves by superior performance and attention to others. Individuals recognized are models of excellence who strengthen the quality of a patient's care and the image of Sarasota Memorial Healthcare System in the community. The hospital board and administrative staff are pleased to present to you, Joe, with the Excel Award of April 2014 in recognition of your demonstrated courteous and caring attitude and contributions toward excellence at Sarasota Memorial Healthcare System. Signed by Gwen McKenzie, Chief Executive Officer, and Marguerite Malone, Chairman of the Board. Congratulations.
Thank you, everybody. I appreciate it. Thanks.
Thank
We
you.
appreciate you. We're gonna keep it.
And now we have a Hero Award winner, Cornelia Sari, LPTA Institute for Advanced Medicine.
Cornelia was taking care of patients this morning and she raced to get here. So Cornelia is our Hero Award for April of 2014. On the afternoon of January 17th, Cornelia entered the Institute for Advanced Medicine Health Fit pool area to begin an outpatient aquatic therapy session. As she neared the therapy pool, she noticed a member floating on a pool noodle. Cornelia approached the pool side and called to the member, who was face down in the water and unresponsive. Cornelia immediately grabbed the member from the side with her arms around the woman to prevent her from falling back into the water. She enlisted the help of a passing cleaning crew who assisted her with pulling the member out of the water and onto the pool deck. The member was unconscious, so Cornelia began chest compressions. The woman roused after 1 minute but was unable to answer questions. 911 quickly reported to the scene to care for the member, and Cornelia remained to provide information and assist as needed. The member had experienced severely low blood sugar and had passed out while floating alone in the therapy pool. It is unknown how long the member had been floating in the pool. It was the observation of all who reported to the scene that had Cornelia not taken decisive and immediate action, the member would have drowned. Cornelia is credited for setting an example of excellent emergency response and saving the woman's life. Thank you.
Again, on behalf of the board, we have this beautiful plaque for you. Cornelia is hereby inducted into the Sarasota Memorial Healthcare System Team SMH Hall of Fame as a hero. On the second day of April 2014 for meritorious customer service, including consistently exceeding the expectations of our patients, families, visitors, and staff, being an example to peers and others, having a personal commitment to excellence, and going above and beyond for individuals in our community. Signed by Gwen McKenzie, CEO, and Marguerite Malone, Chairman of the Board. Congratulations. What a great story.
I would like to accept this award on behalf of all the staff at our facility. Same thing, same patients, and it just happened that I was there at that time, but everybody would have done the same thing. So thank you very much.
Well, thank you very much. We'll move now to the report of the medical staff. Dr. Von Waldner, Chief of Staff, and then after your report, you will introduce our physician presenter today, right?
Yes. Thank you, Madam
very
Chair.
much.
I have one item of action for the board, and that is the approval of privileging criteria for Stingray and Cross-Boss devices. This criteria has been reviewed and approved by the Credentials Committee and the Medical Executive Committee, which recommend your approval.
I move approval of the criteria for privileging Stingray and Cross-Boss devices for chronic total occlusion as recommended by the Medical Executive Committee.
Do we have any comments, questions? Hearing none, all those in favor of the motion, please indicate by saying yes.
Yes.
Opposed? Motion carries. Thank you very much.
And that concludes my report, and I will continue on with the introduction of our speaker. It is with pleasure that I introduce this month's speaker, Dr. Michelle Miller. Michelle attended Cornell University for undergraduate and UCLA for medical school. After completing her pediatric residency at Cedars-Sinai Medical Center, she remained in Los Angeles for a fellowship in pediatric cardiology, as well as a 10-year position in academics at UCLA, eventually becoming an associate professor of medicine in the Department of Pediatrics and director of fetal cardiology at Cedars-Sinai. In 2010, Michelle moved to Florida to join the faculty of All Children's Hospital and resumed her career in academics as an associate professor of pediatrics for FSU School of Medicine. Extensively published, Michelle has spoken at numerous conferences and symposiums. Her latest project in Sarasota is the implementation of the neonatal pulse ox screening program here at Sarasota Memorial Hospital, which is the basis of her presentation today. So without further delay, please welcome Dr. Michelle Miller presenting newborn pulse oximetry testing at SMH, a success.
Thank
Welcome.
you so much. Oh, I'm sorry. That was a hard act to follow, those people that you honored earlier. So thank you. I hope that we can be a little bit close to some of the wonderful things that your other employees are doing here. Okay. You can just use this to click. Okay, great. All right, thank you again for inviting me to speak to you today about a project here at Sarasota Memorial Hospital that is very close to my heart. So I'm very excited to tell you about it. It's called the Pulse Ox Screening Test, and it is a great success story for us here at Sarasota Memorial Hospital. So to start on a sadder note, more infants die from congenital malformations of the heart than any other abnormality in infants. And a third of those infants have absolutely no physical findings in the first 2 weeks of life. So that means a patient, a newborn with complex congenital heart disease, sitting right next to another newborn with a normal heart, may have no physical findings that are picked up. So that means that that infant is discharged home from our hospital as presumably a healthy infant. And unfortunately, when they present later on, we know that they can present in death or in cardiogenic shock. So that means that even though we can help with their congenital heart abnormality, by the time we get to see them, sometimes they're in extremis, which makes their heart surgery more complicated and the outcomes not as well as they could be. In a study published earlier this year, they looked at 3,750 infants that were born with complex congenital heart disease that were not diagnosed prenatally, and they found that 30% of them were indeed not diagnosed until after the 3rd day of life. So we know that our infants go home in about 48 hours most of the time, which means that these infants present once they are home. Unfortunately, in that previous study, 6 infants were first diagnosed at autopsy. So in December of 2011, the American Academy of Pediatrics, along with other associated groups of pediatric cardiologists and cardiothoracic surgeons, made a statement which said, we have something called the pulse ox screening test, which we can do in newborn infants that can detect complex congenital heart disease in infants that are otherwise asymptomatic, and we recommend that all infants have this screening performed. Again, this was December of 2011. So as soon as this came out, we got very busy here at Sarasota Memorial Hospital. So what is the pulse ox screening test? Essentially what this is we use a probe that looks through the skin and it measures the oxygen saturations, and we do this in the right hand of the infant and either one of the lower extremities. And based on this oxygen content, we have an algorithm which lets us know what the risk is for this particular infant for complex congenital heart disease. The test takes about 2 minutes, and it is done on infants between 24 and 48 hours of life. So the frequency of complex congenital heart disease is about 44 infants per 100,000 births, and I've compared it here to the other metabolic screenings that we are required by the state of Florida to perform, and also hearing screening. So you can see that complex congenital heart disease affects more patients than the metabolic screening that we currently are required to do. In addition, you can see that the pulse ox screening has a very high positive predictive value as compared to such screening as for hypothyroidism and even for hearing loss. So it's an excellent test. The cost is $5 that they estimate in this particular study, which shows that it's equivalent to the metabolic screenings that we do and much less expensive to the hearing screening that we are required to do by the state of Florida. And let's look at the clinical results of delayed diagnosis. If we delay the diagnosis of metabolic screening, these infants can go on to have cognitive deficits. If we miss hearing loss, then these patients certainly have language and cognitive delay, and so it's important to initiate therapy right away. But you can see with complex congenital heart disease, the outcome can be death. And so the stakes are very high for complex congenital heart disease, and now we have an excellent test to make sure that we don't miss this. So as soon as this came out, we went to the administration in pediatrics, and they said, absolutely, we need to do this test, but there's 2 issues. One, it's not mandated by the state of Florida, and so we have no infrastructure. We need to build this from the ground up here at our hospital. And number 2, it's not mandated by the state of Florida, so we can't, it's not a billable service. So we need to operate this very lean. So we got our marching orders and we moved forward. So first of all, this is the probe, the pulse ox probe that we use in the neonatal intensive care unit. It's an excellent product, but our infants have to wear this probe for days at a time. And as it turns out, this particular probe is $13. And we said, well, that's too much money for our 2-minute test on our newborn infants. So we went and looked at a few different products, and we found this reproducible pulse ox monitor that gets stuck on with this little foam sticker here, and as it turns out, this is 30 cents. So we said, perfect, that sounds great to us. And then we went to our nurses and we said, listen, this test is going to take 2 minutes, but we need to do it at a time that works well for you, so we're not using a lot of your extra time. Perhaps a moment when you already have the infant in front of you and you're already in the patient's chart. And the nurses said to us, you know what? We do our metabolic screening and our hearing screening at this particular time between 24 and 48 hours of our infant's life. And we said that is perfect, because we know that our nurses' time is priceless and it's difficult to put a dollar sign on that, but we wanted to do it at a time that was as least intrusive as possible. So now we're working on 30 cents and 2 extra minutes of our nurses' time, and we said that's great. The algorithm for the pulse ox screening test can be a little bit complicated, so we made a giant poster that we hung up in our normal newborn nursery so that the nurses, all they had to do was glance up and take a look. The posters that I did not show you are the posters of my phone number, which were all over the normal newborn nursery, and they're all over the order sets. If there's any questions, you call us right away. Whoops. Then we did all of our teaching for the nurses, and we even had a quiz for them so that we knew that they were proficient at the end of their education. And once they passed this, we knew that they were ready to do their pulse ox screening. Of course, we had to make information for our community, and so we had a handout for all of our parents once they arrived to let them know what this new screening was that we were offering at Sarasota Memorial Hospital. So 3 months after the recommendations came out from the American Academy of Pediatrics, we had completed our nurses' education. We had our handouts for our families. We had our order sets ready. I gave lectures to the pediatricians, the neonatal intensivists, the obstetricians, the emergency department, and of course our echo lab, so that when they got orders saying that this infant needed an echo, they knew exactly what that echo was for. So we rolled out on April 24th of 2012, And so during our first year, we screened 2,233 unique patients in the mother-baby unit. 2% of our population were not screened for various and assorted reasons. I'd be happy to review it another time. We had 2 patients that failed the first screening, but on follow-up were normal, which is exactly what our protocol recommends. There was 1 infant that had an echo inappropriately ordered for that infant, and that's because the nurse went off the protocol. And we had 4 patients that were marked as normal when actually they should have failed. So we went back and did additional education for those particular nurses, and we reviewed those infants to make sure that they were healthy, and they were fine, thank goodness. So in that year, we had 5 patients that had complex congenital heart abnormalities that were not prenatally diagnosed, but all of these infants were diagnosed in the first 24 hours of life, so they never made it to our pulse ox screening. So while we still know that these infants come to our hospital undiagnosed after they're born, these particular infants were not picked up by our screening because they were picked up before the screening process happens. So how are we doing in our second year? Well, April 24th is our cutoff for our second year, and so all of the data is starting to percolate in, and we're hoping to see even better numbers than we had our first year. But I do want to bring to your attention that in October of 2013, we had a newborn that failed the pulse ox screening test 3 times per our algorithm. The patient went on to have an echocardiogram or an ultrasound of the heart, and the patient was diagnosed with a disorder called coarctation of the aorta, and the infant was transferred to our neonatal intensive care unit. Without getting too technical, I have a picture here of the heart. The blue is the right side of the heart, the red is the left side of the heart, and off of the left side of the heart is a giant vessel called the aorta, which brings the red or oxygenated blood to the head, neck, and the rest of the body. And coarctation of the aorta is a narrowing that occurs right here in the distal portion of the aorta, and these infants can present up to 2 weeks of life, and they can present in extremis and even in death. And so our infant was eventually transferred up to All Children's Hospital, where the surgeons cut out this narrowing and sew it back together. The surgeons hate it when I make it sound like what they do is easy. I assure you it's with great grace and complication that they do this procedure. And here is our infant Evan, who did wonderfully. He is now home. He was discharged after about a week at the hospital, and he is doing terrific with no further symptoms, and we are thrilled. Around the same time that Evan was born, October 2013, a journalist living in Connecticut wrote an article about his child who was diagnosed with the pulse ox screening test after it had just been started in Connecticut. And he wrote, "The $13 test that saved my baby's life, why isn't it required for every newborn?" And I would say here at Sarasota is the 30-cent test that saved Evan's life. Why isn't it required for every newborn? Well, as of December 2013, all the states here in red are the states in which legislation has been enacted and it is mandated. And you'll see that the state of Florida is a very interesting stripe of red and purple, which I'm not exactly sure what that means, but it means that legislation has been enacted and yet legislation has failed. So as of 2013, the state of Florida does not mandate newborn screening, but it has appropriated funds for this screening, and it has asked the state's newborn screening program to begin the infrastructure so they can start collecting data. But I do want to tell you that it is because of all of your commitment to our community and the children of our community that we have been able to successfully roll out this program 2 full years prior to any mandate from the state of Florida. And I do also want to tell you that other hospitals, not just in our area, but across Florida, have contacted us to ask how we have so successfully rolled out this program so that they may do the same. So I thank you from Evan and from his family and the other children across Florida that we don't even know that we have saved. So thank you so much, and thank you for your time, and thank you for the honor of caring for the children here in this hospital. Thank you.
Thank you so much.
Marguerite, I have
Yes.
a question. You mentioned you use the right foot.
Yes,
Why?
the right hand.
And the right foot.
Either foot. Either foot, but the right hand. And that's because of where the narrowing occurs in the aorta. Sometimes the left hand can be distal to the narrowing, and so we check the oxygen content in the right hand and either foot. It has to do with how fetal circulation continues in the first 2 weeks of life, occasionally in these infants, and so we see an oxygen difference of greater than 3% between the right hand and either feet.
Thank you very much.
My pleasure, my pleasure.
Thank you. It's very exciting. And now the auxiliary report. Robert Duquel, President.
Thank you. The members of the auxiliary hope that you enjoy the cell phone holders that I passed out earlier. They're not only good for your cell phones, but accommodate other things like your driver's license and perhaps some petty cash. The uniform sale on March 18th and 19th assisted in adding nicely to the treasury. A new vendor, International Jewelry, will offer jewelry and handbags at a show on May 6th and 7th. The show will be in rooms 4A and B, beginning at 7 a.m. on both days and ending on 5 p.m. on the first day and 4 p.m. on the second day. The vendor offers, quote, buy one, get one 50% off, unquote. The teenage volunteers will be showing up within the next few weeks. And as I mentioned earlier, there's a new service which will be in the cardiac section on the 7th floor of the courtyard tower. This is a new volunteer service which will be directed by Lindsay Tuttle, RN, a previous teen volunteer. On April 30th, the auxiliary will conduct a retreat to review the current needs of the hospital and new or additional ways to provide service. A further report will be provided in May. That concludes my report.
Thank you very much. And now, Ms. Alex Quarles, President, Sarasota Memorial Healthcare Foundation.
Thank you, Madam Chair. All great presentations this morning. Just wanted to wrap up a few comments. Those of you that were able to join us with Dr. Oz, that was a great day, and we hope to be able to continue to do more things of that nature. We had about 400 people in attendance, and I think it went very well. All of our sponsors had an opportunity to participate and visit with him, and we got some great coverage out of that as well. I'd like to thank the SMH security program for making sure that Dr. Oz came and went safely. Thank you very much. We had our legacy luncheon with Dr. Concha that spoke about stroke, and actually had a patient there to provide a demonstration of the work that he has done, and the patient who wasn't able to walk was walking around and talking, and that was very encouraging to an awful lot of people. Tomorrow is our Professional Advisors Network. We have Richard Lewis from Shoemaker, Loop, and Kendrick coming in to talk about a change in some of the tax codes. Is that correct, David? Close? Yeah, changes in tax codes. And that's our ongoing event to encourage our state and financial planners to take this information to their clients and hope that they will look favorably on using the hospital and donating to us. The EPIC campaign has started. EPIC stands for Employee Partners in Caring, and that is ongoing now. Their goal is $100,000, so I think they're getting close to that. But probably the piece of news that I'd like to leave with you that is fun is that we received a grant from the Roberta Leventhal Sudikoff Foundation for $2 million. The pledge is in. It will be paid out over 5 years, and they will be naming the 7th and 8th floors, cardiac floors, in the new courtyard towers. So we will be doing a ribbon cutting sometime over the summer when they're there. And that concludes my report. Oh, other than the golf tournament that's coming up. If you haven't registered, please do. Thank you.
And the date for that, Alex?
Second.
May
April
2nd. Okay, thank you very much.
May 2nd. April 2nd.
And now the Secretary's report, Mr. Darrell Henry.
I'm the substitute secretary, filling in for Mr. Tom Towler, who is on a Mediterranean cruise. We hope he's having a great time. Tom, we miss you. But to fulfill the job, the schedule includes on May the 1st at 7:30 a.m., the PSI board meets. At 9:30, the Finance Committee meets. At 10:30, Investment Committee meets. Then following that, on May the 19th, at 11 a.m., the board review of the finances occurs. On May the 19th, the public board meeting starts at 1 p.m. right here in the Waldemere Auditorium. Thank you, Madam Chairman. This concludes my report.
Thank you, Mr. Henry. Now we move on to the treasurer's report. Mr. DiVirgilio.
I only have one item this morning, that's bad debt and charity care. I move approval of the bad debt and charity care for the month ending March 31st, 2014 in the amount of $11,199,000.
Second.
Any comments or questions? All those in favor of the motion, please indicate by saying yes.
Yes.
Any opposed? Hearing none, motion carries. Thank you very much. Thank you. And the first operations report, Mr. Bill Wojin, Chief Financial Officer.
Thank you, Madam Chair. I have the financial highlights for March 2014, and this represents 6 months of our fiscal year, so we're halfway through. And we'll start off with operating revenue for the system. For the month of March, our actual was $51,672,000 compared to a forecast of $50,544,000. Fiscal year to date, which is 6 months, $279,819,000 compared to a forecast of $276,579,000. Our total expenses for the system for March, actual expenses of $48,885,000 compared to a forecast of $48,627,000. Through the second quarter of fiscal 2014, actual $276,875,000 compared to a forecast of $276,188,000. Our operating income for the system for March, $5,152,000, which represents an operating margin of 9.3%. That compares favorably to the forecast of $4,247,000, or a forecast operating margin of 7.9%. For the 6 months of the fiscal year, we're at a operating income of $17,346,000, which is an operating margin of 5.8%, compares favorably to the forecast of $14,337,000, forecast operating margin of 4.8%. For the hospital's paid hours per adjusted admission, we're at 127 compared to 128 last year. And fiscal 14 for the year, we're at an average so far of 125, just one up from last year's 124. For operating statistics for the hospital, the average daily occupancy for the month, the 6 months ending March, 403 patients compared to a forecast of 389 patients. Our average length of stay, 4.54 days compared to the prior year of 4.72 days. Our admissions through 6 months, 14,586 compared to a forecast of 13,269. Our surgery cases through 6 months, 9,737 compared to a forecast of 10,152. Our births, 1,458 compared to a forecast of 1,366. Our outpatient registrations for 6 months, 205,069 compared to a forecast of 216,173. Our emergency care center registrations, 55,059 compared to a forecast of 51,619. The hospital's case mix index for the fiscal year to date, all patients 1.64 and Medicare patients 1.77. Madam Chair, that concludes my report unless there's any questions.
Thank you very much. And next, Ms. Jan Mock, Chief Nursing Officer.
Good afternoon. I'd like to just recognize a few highlights that we've had since the last board meeting. On March 30th was Doctor's Day. And as we have Dr. Sidney Van Waldner and Dr. Miller here, who represent our wonderful physicians, we did have a celebration on the 31st for all of our physicians, over 800 of them, who serve our community with the highest medical care possible, and we are so fortunate. We celebrated them in the morning of March 30th starting at 6:30 with a thank you and a welcome in all the entrances of the facility, and a wonderful luncheon, which some of you did go to in the physician lounge, which we thank them for all their service and everything they do every day. We are so lucky to have such a quality medical staff in our organization and in our community. Next, we will be celebrating next month Nurses Week. And that always starts on May 6th and is a full week until May 12th. The National Nurses Week begins each year at this time, and it's in recognition of Florence Nightingale's birthday. When people ask, and I get this every year, usually around Physicians' Celebration Day, why do nurses get a week and doctors get a day? So I'll briefly give you the history of that. It's not something the hospital did, but it's a national campaign. In 1974, a week was designated by the White House as National Nurses Week, and President Nixon issued the proclamation. In 1982, President Ronald Reagan signed a proclamation that made May 6th National Recognition Day for Nurses. In 1990, the ANA Board, American Nurses Association Board of Directors, expanded the recognition to nurses for that week-long celebration for May 6th through the 12th as National Nurses Week. And in 1997, the ANA also designated May 8th of that week as National Student Nurse Day. So that gives you a little history. If you want that written down, I can hand that out to you all. The theme this year is Nurses Leading the Way. And the ANA states that everyday nurses step forward, embracing new technologies, resolving emerging issues, and accepting every challenging role in their profession. They lead the way for their patients, colleagues, organizations, and healthcare industry as a whole. And that week we will be celebrating our magnet nurses with their best event that they like, which is Blessing of the Hands. We will have unit celebrations. We will have an educator who will be speaking. It's Dr. Meredith Rowe from USF, who will be speaking on writer's block, Flip to Cure, guiding in publication, a guide to publication. It's a very busy month also that we've had, and a very successful month with implementation of our new pharmacy IT system. There was a lot of planning and effort that went into this, and I want to thank Dennis Baker and his team in IT, and the pharmacy, Jim Young and his team, Dave Youngst, for the great planning and the dedication to the process. And the next phase will be rolling out the barcoding, which will be starting next week, which is barcoding for medication administration. And as we know, that is the safest way of administering medications. And so we're very excited about that, because on our journey to safety here at Sarasota Memorial Healthcare System, we're always looking for the safest way to do things to keep our patients safe. The next thing that we did was implement the new perioperative system, the GE system. And it actually has two phases. First one was the staff documentation, and then the anesthesia system. And I see Cindy smiling over here. The first phase went very well. Our staff had already been up on a computer documentation system. And I want to thank Pam Ramhofer and her team, and David Patterson and the perioperative team for that successful rollout and implementation. We are now working on the anesthesia system planning for go live sometime, we think, in August. I want to thank the IT team, Dr. Whitman, Dr. Swartz, and Dr. Bankus for their hard work and leadership in directing us into this process. And last of all, through this very busy season, I want to thank all of the members of Sarasota Memorial Healthcare System for all their hard work. We had a very busy season, and they did a wonderful job of managing that high volume in a very compassionate and safe and quality way. So we and I and the leadership team want to thank them for all of their hard work that they have every day, but particularly through this very busy season. And that's all that I have, Madam Chair.
Thank you very much. And I want to make just a brief board report on a legislative visit, which we did the end of March. And two groups were visiting around with various folks. Gwen, as CEO of the hospital, and I, as chairman of the board, joined the Safety Net Alliance at meetings with the lieutenant governor and several senators and several representatives in order to discuss the health care issues. As everyone knows, our primary and just very urgent feeling and need is that the Medicaid expansion take place for this state. That has not happened. We've been working on it, as have others, for quite a while, and at this time that appears is not going to happen, at least this year. The second thing that we talked about, and this particularly was the issue that Gwen and I dealt with, was the change in the way that Medicaid payments are going to be made through a tiering system. My role was to speak to how it was for us as an elected board to think about a change which was coming in a law that developed a new tiering system that allowed for a bottom tier and 30% of the money to go to institutions that do not provide any or much Medicaid treatment to patients. And so the impact of that to us as a publicly elected board with taxing authority, and the fact that that did not sound like a very sound plan or way for us to be using taxpayer money, and it was a problem for us. So that was the discussion that we had. The Safety Net Alliance has done a tremendous amount of work in dealing with this issue for all of the hospitals in the state that are in the Safety Net Alliance. And of course, Gwen was the previous president of that group. And so we were hoping to make some impact, at least have this onerous aspect of the new law delayed. There also was inaction in Washington to try and get a waiver for Florida so that more money would be coming in for Medicaid. And that, in fact, has happened. There is more money coming in. And the Safety Net Alliance had a lot to do with helping to make that happen. And as a result of the more money coming in, at least it appears that there will not be this tiering system happening for this year. And hopefully in the future it will go by the boards because there'll be a new system. So we have had some progress there, is what I'm wanting to say. And we really do appreciate the Safety Net Alliance and FHA and all the organizations that are working to try to make this more prevalent. So that is that report. We don't have any plans to go back to Tallahassee at the moment, but this has been a moving target, so we don't know whether we might be going again. So at any rate, thanks to all the people that put in hard work on that. And now we'll move to committee reports. And for the Audit Committee, Mr. Darrell Henry, Chairman.
Thank you, Madam Chairman. The Audit Committee met at 11:55 a.m. on April 3rd. Mark Thornton, the Executive Staff Audit Director, reported on completed audit projects for the second quarter. These projects include some very special activities, which include audit of security procedures in high-risk lockdown units of the Courtyard Tower, update on a drug diversion prevention project, HIPAA meaningful use risk analysis and gap assessment, bed tower construction audit, continuity of steel claims, which you may remember, included a carbon fiber addition to the roof structure of the Courtyard Tower. and final closeout audit of the courtyard tower. Identity and access controls, robbery training, review of the Suncoast Regional Data Center, and status of the semantic encryption process. Among all projects in process or planned for the third quarter are getting to best practices for drug diversion and prevention, audit of business associate agreements, breach response, pharmacy vault operations, and wire transfer controls. Then I'm going to do EOC validation team rounding. Since no further business was brought before the committee, the meeting was adjourned at 12:20 p.m. Thank you, Madam Chairman. This concludes my report.
Thank you, Mr. Henry. And we'll move on now to the Governance Effectiveness Committee. Ms. Alex Miller, Chairman.
Thank you, Madam Chair. The committee met on April 3rd, and there are two highlights for you. The first, the committee received a brief update on the compliance program. Key measures of the program's effectiveness were covered, including the actively functioning committee structure, the risk-based annual compliance audit plan, and the status of the comprehensive risk assessment project. The results of the most recent employee survey on the compliance were shared, showing improving scores on all questions and scores well above national benchmark surveys. The second highlight was the committee discussed appointments of community members. The committee reviewed the process implemented 2 years ago to provide for periodic transition of community members that serve on board committees. The committee reviewed current community members and reviewed the resumes of several individuals who have an interest in serving as community members. There will also be an ad in the Sarasota Herald Tribune in June or July requesting additional resumes in case anyone that's watching is interested in applying. Please do look for that ad. The committee reviewed each of the board's committees to determine the number of potential openings on various committees. And there will be an update at the June meeting. And that concludes my report.
Thank you very much. Move on now to the Mission and Planning Committee. Mr. Carter, Chair.
Thank you, Madam Chair. The Mission and Planning Committee also met on April 3rd, and we started with the Lab Information System report. And David Verinder introduced Charlene Harris, Director of the laboratory, and she discussed the Lab Information System, which is a series of computer programs that process, store, and manage data from all stages of medical processes and tests. The current system was purchased in 1987 and is in a decline and is not able to be upgraded. She discussed the due diligence conducted on available lab information system companies, and she also discussed the current limitations of the LIS. Then Ken Trotter, manager of the laboratory, provided examples of how the new system will improve over the old system. He used the example of an FPG physician using the EMR, or any physician using the EMR, and other community physicians not on the EMR using the physician ordering system, which is web-based. He reviewed finances and requirements of the system, and the total purchase price will be divided between the 2014 budget and the 2015 budget. At this time, I move approval of the purchase of the recommended lab information system at a cost not to exceed $3.5 million, which will be split between the current and the next budget year as recommended by the Mission and Planning Committee.
Second.
We have a motion and a second. Any discussion or questions? If not, all those approving the motion, please indicate by saying yes.
Yes.
Opposed? Motion carries. Thank you very much.
Next, we discussed the Bee Ridge Selection Committee, and Tom Perigo gave the selection committee meetings held on March 20th to review and select the architects, engineers, along with general contractors for the interior of Bee Ridge campus build-out for the transition of the main plaza staff. And at this time, I move approval of the rankings of the general contractors for the renovation of the Bee Ridge property to accommodate the main plaza moves
as recommended by the Mission and Planning Committee. The first was Willis A. Smith Construction, who placed on top. The second was Tandem Construction, and then third, Core Construction.
Do we have a second? Any questions or discussion? All those in favor of the motion, please indicate by saying yes.
Yes.
Opposed? Motion carries. Thank you.
Okay. Next, I move approval of the rankings of the architects and engineers for the renovation of 1852 Hillview Bee Ridge. Okay. For the renovation of the Bee Ridge as follows, as recommended by the Mission and Planning Committee. First was Carlson Studio Pluckett Rasich. Second was LGA Architects, and third was C. Allen Anderson Architect.
Any discussion or questions? If not, all those in favor of the motion, please indicate by saying yes.
Yes.
Opposed? Motion carries. Thank you.
Okay. And our last item was a discussion on the rehab facility. And David Verinder discussed the inpatient rehab facility, which was introduced to the board 2 months ago. After that meeting, David's team went back to look more closely at modifications based on feedback received at that time. And then he then presented a review on project scope, facility options, proposed timeline, proposed costs, and initial investments. David reported that we will relocate our 34-bed comprehensive rehab unit to the new facility with capacity to expand as needed in the future. Option 1 is 4-story building, and option 2 is 4 stories with the option to go to 9 floors. Commonalities of the two options were reviewed, site plan was reviewed, and an artist's rendering was presented. David reviewed the floor-by-floor views of the building also. Tom Perigo then discussed utilization of the courtyard tower approach for project planning for this facility and discussed use of the public selection process for architect engineering firms as well as the general contractors. Then David discussed the 2014 timeline and the project costs for option 1 projected at $42 million, option 2 at $57 million. An initial investment of $2 million will be for the architect, engineer, and general contractor schematics. This will then come back to the board by the fall with the final project and final budget for final approval at that time. David and Bill Wolchin advised that they will be using the operating cash to finance the project, and final project completion is projected to be the winter of 2016. At this time, I move approval of the expenditure of $2 million for initial design, planning, and contractor work for a rehab facility as recommended by the Mission and Planning Committee.
Any questions or comments? All those in favor of the motion, please indicate by saying yes.
Yes.
Opposed? Motion carries. Thank you.
And that concludes my report, Madam Chair.
Thank you very much. We'll move on to the Quality Committee. Mr. Robert Strasser, Chairman.
Madam Chair, as you know, the Quality Committee meets in closed session, but I do have a motion that I would like to propose. I move approval of the Emergency Operation Plan for 2014 as recommended by the Quality Committee.
Any questions or discussion? If not, all those in favor of the motion indicate by saying yes.
Yes.
Opposed? Motion carries. Thank you very much. And we'll move on now to the President's Report. Ms. Gwen McKenzie, CEO.
Thank you, Madam Chair. We are now 6 months into our year, so this is our fiscal year-to-date report card, the leader report card, and I'll go through this in some detail for both you and our community at home. The service pillar is our, what we call the patient experience, and that would be our HCAP scores compared to national results, and our outpatient is Press Ganey. In HCAPS, we wanted all of the question domains to be above the CMS average at 50%. So 9 at 50% is our goal. Currently, we're at 7 at 50% year-to-date, so we've got a little bit of work to do, and we'll see that detail. Outpatient in Press Ganey, we have about 800,000 encounters now, and our goal is to be at the 83rd percentile of patient satisfaction or experience, and currently we're at 80% year-to-date. Our Gallup employee survey we'll be conducting in the next couple weeks here. And thank you to all the board members who attended the town hall meetings that we had. And thank you to Jan for attending the night rounds that we had. And Mr. Carter always attends our night rounds as well. So thank you to all of you. It really, the employees really appreciate when you come to the town hall meetings. The merits on time, we're currently at 97% with a goal of 95. That's a joint commission requirement. Value-based purchasing, this is our reimbursement based on quality metrics and outcomes now. And our goal is to receive all of our appropriate funding and reimbursement, so over 100%. Right now you can see we're at 99.8%, so we've got some room to make up there. The organization percent of patient safety readiness is our rounding and interviewing and auditing on a monthly basis to ensure that we're ready on any day, given a joint commission or any other type of survey. Our goal is to be 95% ready. Currently, we're at 99%. Infection prevention, this is an overall standardized infection rate of 3 different types of infection: surgical site infection, catheter-associated urinary tract infection, and central line bloodstream infection. Our goal is to be less than the rate of 1, and currently we're just a little bit over 1, so there's a lot of effort, especially in the catheter-associated urinary tract infection, going on with the physicians and nurses. In the finance pillar, you heard Mr. Woljan's report. Our goal is to be at a 4.2% positive operating margin. Currently, we're at 4.7%, so we're exceeding our goal year-to-date. Strategic growth, inpatient admissions. You know that this is the first time in probably 5 or 6 years that we have exceeded both 25,000 admissions and really grown our inpatient volume. So we're at 26,500, exceeding our goal there. Outpatient registrations, you can see we're a little short of the 812,000. You also saw in Mr. Woljan's report that we have more outpatient volume than we did last year, but our goal is 812,000, and we're currently at 794,000. In terms of the detail for HCAPS, which is the Hospital Consumer Assessment of Healthcare Providers and Systems, we call that the patient experience. You can see the clusters of questions that are called domains down the left-hand side of the slide here. You can see the areas that we're succeeding and the areas in red that we have some work to do. You can see the quarters. We've been improving at 7. In this last quarter, we were at 6, so we've got some work to make up there. These are all the areas that are on the outpatient Press Ganey system, or the likelihood of recommending. You can see who's above the 50th, above the 83rd, and then below the 50th where there's work that needs to be done. So our actual results are the 80th percentile overall, and the goal is the 83rd percentile. This was our Dr. Oz event that Alex referenced. He is a very, very nice, down-to-earth person. I think those that attended would all agree. He spent an inordinate amount of time with us, a half day. All of that time was donated thanks to our relationship with Columbia, where he is a practicing cardiac surgeon. In fact, not only does he practice, but he invents some of the devices that Dr. von Waldner talked about today for advancing the cure of cardiac stenosis and mitral valves. This is Dr. Sell with him, our own Dr. Sell, our chief of cardiac surgery, who Columbia actually recruited on our behalf. He and Dr. Oz know each other from training. And then you can see the whole group of us. There's Alex, myself, Dr. Oz, Jan, our Chief Nursing Officer, David, our Chief Operating Officer, and Mr. Merrick, who's also on the board. We just really had a terrific day. And speaking of people, I wanted to recognize Alex, who tomorrow is being honored by the Community Video Archives. Congratulations, Alex. We're very proud of you, and we'll be there to support and cheer you on. It's a wonderful accomplishment. Saturday, you may not know, but the March of Dimes does an awful lot for our premature babies in the neonatal intensive care unit. There's a lot of funding toward drugs and other supplies that those babies need that the March of Dimes supports through their fundraising. So our clinical group asked that I chair the walk this year, and I am obviously doing that. And we will be walking on Saturday, April 26th, right at the base of the Ringling Bridge. And I appreciate so many of you signing up, and our mother-baby nurses will be there as well. We're also having our NICU reunion that day, which we do every 3 or 4 years. And that's usually attended by about 300 to 400 of our NICU families, including the children, that we saw them as tiny premature babies, and now some of them are grown little people and doing just wonderfully. So it's always a great day, and I'm sure we'll have a great time on that Saturday. There's actually a fundraiser tonight at Gecko's. Our team, which is called, what is our team called, Jan? The Babe Magnet Walk Team. So the Babe Magnet Walk Team will be at Gecko's should you like to show up and support our fundraising. Everything goes toward the March of Dimes. We're trying to raise $200,000 for them, and I think we'll be successful. And then here is the Northport Community Expo, attended by Mr. Henry, our board member. And you can see 3 of our obstetrician gynecologists were there in support, as well as our physician liaisons and our staff from our Northport Center. This was Dr. Sell, I think, attending his first Orioles game with Dr. Strasser, and it looks like they were having a fun time with the mascot. We're currently launching and have launched with the Gulf Coast Community Foundation something called Skip a Lunch program. And what that is a summer program to feed the children. Over 50-some% of our children in the school system are required to have lunches by a voucher program because they can't otherwise afford the food. And so you think about that during the school year, and then you wonder what happens during the summer. And this is the campaign to make sure that same effort continues during the summer with the All Faith Food Bank and community support like ours through fundraising, and we're doing a food donation as well as fundraising in our various food kiosks and areas to the All Faith Food Bank. This was our Health Information Professional Week, which was a few weeks ago. Everyone here celebrates with food, so I'm sure you can see that, but they do a wonderful job protecting our patients' privacy, and this is our staff in the Health Information Management. We also had a wonderful Volunteer Appreciation Week. I think there's a contest for every department to make sure they recognize their volunteers even bigger and better. So we're really appreciative, Bob, of all the work that our volunteers do. This was one of our trips to the Capitol, the one before Marguerite discussed, where we met with the governor and talked about the very same issues. Around me are the CEOs of the other safety net health systems, and that's Bruce Rubin, the president of the FHA, that's sitting directly ahead of me. These are our core measure results, and we strive to have every single core measure to be absolutely perfect or 100%. You can see in December we did quite well, with the exception being, and Alex, we discussed that in our pre-meeting today, the discharge instructions and how important that is in making sure patients understand before they leave us about their medication management and return visits and the like. And you can see we missed the discharge instructions with but one patient, but that caused us to drop to 95%. That requires some work. This is something we call the Appropriate Care Measure Score. What it attempts to do is compile all the 60-some different core measures and whether or not we succeeded in delivering that particular result to that patient, one patient at a time. And for the month of December, we were at 99%. And you can see a nice upward trend here. This is what Dr. Concha talked to us about a little bit ago, and that is we were awarded the Gold Plus Get With the Guidelines stroke status through the American Heart and American Stroke Association. It is the goal to ensure that half of the patients who present to the emergency room get the IV thrombolytic or the TPA within 60 minutes if they're eligible for that clot-busting drug. You can see in Q4 2013 we were at 44%, and when Dr. Concha just presented this to all of you, we were over 50. Now the next, you can see recommendations and next steps. This is from our quality report. We're trying to increase the goal from 50% to 70% of patients getting that TPA or clot-busting drug within 60 minutes of their arrival to the emergency department. You met all the Florida State medical students in July when they started. This is the class that just received their match results. This is the class that will be leaving us effective June. But it's really nice to see all of the great places that they placed at, places like Wake Forest, Loma Linda, University of Texas, quite a bit of University of Florida, and USF. Louisiana State, University of Tennessee, University of Colorado. And you can see a wide array of programs that they were accepted to, from emergency medicine to primary care to OBGYN to surgery. So congratulations to our students. They're so well trained. This was the trauma editorial that we wrote following numerous inquiries. And I want to thank Kim and Ellen for doing so much work on this to make sure we could really present it in a way that the community could understand it once and for all, why we are not a trauma center. And we received a lot of positive feedback that our editorial was very understandable. This is largely political at this time. That doesn't mean it's the right thing to do for our community, for us, and so we won't be proceeding to apply as a trauma center. Kathleen Houseworth followed me in a guest editorial that talked about advanced planning and advanced directives to make sure living wills are up to date. They're filed with family. There's a regular discussion of what that means with key family members, and it was really a well-done article. This was just last week. We participated with the airport in their disaster readiness exercise, and the scenario was a refueling fire on a loaded aircraft that was simulated at the airport gate, and the victims that were injured in the event then came to us for treatment. So in the, we call it the MASH unit, the bottom floor of our south garage, we can actually convert to a MASH hospital with hospital beds, heating and air conditioning, pretty much everything that we could do inside the hospital. And the value of that is if you have victims that are contaminated with gases or other kinds of exposure, that the worst thing you can do is bring them into the emergency room or into a hospital, because you then have to quarantine everyone around them. So these poor victims, which were all our public safety officers, you can see them there. It was a cold day, and they had to take a cold decontamination shower right there in the parking garage. So hats off to them. There was a great response. We always learn a lot from it. It's always about communication, and that was really the theme of that day, ways that we could improve the communication. Then, of course, here's our new Bee Ridge Urgent Care Center on Bee Ridge Road and Center Gate, and we had our grand opening. We opened it April 1st, and we said no fooling, and we had Frank out there standing with a sign. And since April 1st, we've had a really wonderful response. We've been seeing, and this is all of our board, Jan, myself, David Barrender, and Reuben Holland, all participating in the ribbon cutting. Since the day we opened, we've seen 300 patients, so we've done very well in terms of community response. It's very visible, it's easy to get in and out, and I think we hit a home run. With that, I'd like to read a quick patient letter. Dear Gwen, first let me say I'm sorry I missed the opportunity to see you this year for Girls Inc. award recipients. I understand it was a lovely event. The reason I did not attend was because my sister was admitted that day to Sarasota Memorial Hospital. I am fortunate because I don't often have to visit hospitals personally or for friends, but my sister, who was visiting with me and also goes for dialysis treatment in the Waldemere building, had to be admitted to Sarasota Memorial directly from her treatment due to internal bleeding and a very low blood count. It was my very first opportunity to visit your new facility. The new facility is impressive, but it is in no comparison to the exceptional quality of your sensitive, caring, knowledgeable, and highly professional staff. My sister, who is a New Yorker, aka jaded, was blown away by the immediate service and proficient and sensitive care she received at all levels of her 3-day stay at the hospital. Then on March 31st, I had another unexpected chance to visit Sarasota Memorial when a friend of mine was almost hit by a truck while riding her scooter and incurred a bump on her head. I couldn't believe I was back at the hospital twice in 1 month when I had not been there in over 3 years when my brother had broken her hip. Everyone dreads going to an emergency room. Well, they can get over that if that emergency room is at Sarasota Memorial. Everyone we encountered, from the security officer, the intake nurse, the emergency room nurses, the doctor, and even the valet service, was exceptional. Again, I was with another jaded New Yorker who was so impressed with the sensitivity, humor, caring, and professionalism of the staff, she couldn't believe it and talked about it all the way back to her home. And she's still talking about it. People like to complain when things don't go their way, but they don't always say thank you when it does and even exceeds expectations. I didn't want to be one of them. Thanks to your leadership, the Sarasota community has an outstanding medical facility in its midst. We're so fortunate to have a hospital of this quality to provide us with the medical care that we need. Look forward to seeing you in the future.
Very nice.
Any questions? Thank you.
We have nothing on the consent agenda today and no public comments, apparently. So legal matters, Ms. Caroline Kalish.
I don't have a report very often, and I hope at some point to have an interesting report, but not today. As you all know, the official records of your meetings are your minutes, which Donna takes and records, and that you approve at your subsequent board meetings. However, at some point in time, you used to videotape your meetings, which were informal records of your meetings. You did that for many, many years, and you have hundreds and hundreds of videotapes. They are not of archival quality. They, at best, have minimum entertainment value. And so some more than others. So I'm just letting you know, as a matter of information, that you will be destroying those. You are supposed to save them for 2 years post the date that the record is made official, the meetings are made official. And so you will be preserving them for that period of time, to the extent you even have them in that time frame. But otherwise, you're going to be getting rid of massive amounts of charming, anachronistic board meetings. And that is my report for today. I tried to make it as interesting as possible.
Thank you. Is there any other business to come before the board? If not, the meeting is adjourned.